Now, I wish I had more time, but I'm going to move on to immunotherapy in the neoadjuvant and perioperative setting. And here, this is an area I'm quite familiar with over the last several years. There's been a lot of progress in this area. This is an overview of the reported global phase 3 immunotherapy trials in surgically resectable lung cancer. So as mentioned earlier, we have CheckMate 816. This was nivolumab plus chemotherapy for 3 cycles only for stage 2 and 3 non-small cell lung cancer. This has been approved in many centers globally. And one key difference between the FDA and the European Medicines Agency is that the FDA have approved this for all comers, as have most other jurisdictions, whereas the EMA in Europe restricted the approval to PD-L1 positive lung cancer. We've also had 2 approvals of adjuvant immunotherapy. So the Empower-010 trial showed a significant disease-free survival benefit for atezolizumab after adjuvant chemotherapy for PD-L1 1% and above resected non-small cell lung cancer. It should be noted most of this benefit was seen in the PD-L1 50% and above group. So it's that group that I would really think about this regimen for. For the 1 to 49 group, I'm more comfortable with neoadjuvant or perioperative treatment. We also have Keynote-091. So this trial looked at pembrolizumab after adjuvant chemotherapy, but this was not mandatory. However, the labels in Europe and America have required adjuvant chemotherapy. This trial was somewhat confusing in that there was a benefit seen in PD-L1 low and negative disease, but not a significant benefit in PD-L1 high disease. So this has left us in something of a quandary in terms of deciding about adjuvant immunotherapy with these different findings in different studies. And most recently, we have 3 positive phase 3 perioperative trials. The Aegean trial, the Keynote 671 trial, and the CheckMate 77T. And this was probably predictable based on the results of CheckMate 816, but it raises the big question, which patients need just neoadjuvant therapy and which patients should have a full perioperative regimen. Important to note that all of the labels, particularly in the US, require the patient to be a candidate for chemo. So we don't at the moment have an option to treat a patient with neoadjuvant or adjuvant immunotherapy without giving them chemotherapy as well. Briefly, to talk about CheckMate 816, this was a phase 3 trial conducted in Europe, Asia, the United States. The majority of the patients were actually enrolled in Asia. Patients with known EGFR or ALK alterations were excluded. Patients were randomized to a control arm of chemotherapy for 3 cycles, or the investigational arm of chemo plus nivolumab for 3 cycles prior to planned surgery, which was planned within 6 weeks. And there was no further mandated adjuvant treatment. So the patient and the doctor could decide whether to receive further chemo, but it was not required. Primary endpoints were pathologic complete response and event-free survival, both by blind and independent review. These are the demographics. You'll see with nearly all of the perioperative trials or neoadjuvant trials that the majority of patients have stage 3A disease, or even stage 3B in some of the more recent perioperative studies. And there's a higher proportion of patients with squamous lung cancer in the perioperative trials than in the adjuvant trials. About half of the patients here had PD-L1 positive disease, which interestingly is lower than in the perioperative trials. So more PD-L1 positive disease in the perioperative trials, fewer patients with perioperative or with PD-L1 positive disease in this trial. This was the breakdown of patients. Just about 80% of patients in both arms, slightly higher in the Nivo plus chemo arm, had definitive surgery, and fewer patients in the Nivo chemo arm got adjuvant therapy. So what about the surgical outcomes? So in general, these all favored the chemo-Nivo arm. You'll see shorter surgeries in most cases, fewer pneumonectomies required, more lung-sparing surgery if the patients got Nivo plus chemo. And no significant impact on toxicity. So usually when we add a new drug to a standard therapy, we expect more toxicity. We didn't see this in CheckMate 816. And in general, there were no enhanced delays from the addition of nivolumab to chemotherapy. This was similar across both arms. And most of those delays were for administrative reasons as opposed to adverse events. So last year, we had a 4-year update on this trial showing a sustained event-free survival benefit with a hazard ratio of 0.66. At 4 years, about an 11% difference favoring nivo chemo. And we had a 4-year update on overall survival as well, also showing a trend towards improved overall survival here in the left of the screen, 13% difference favoring nivo plus chemo. But at that point, this was not statistically significant. However, since then, we've had a press release suggesting it is statistically significant, and I will be presenting the final overall survival data from this study at the ASCO meeting. So I look forward to discussing that further at that point. An important point here was at 4 years, those patients who had a pathologic complete response do really well. So the 4-year overall survival was 95%. And if you had a pathologic complete response versus just 63% if you did not. What is the impact of neoadjuvant therapy? Well, it's primarily in reducing distant recurrences. You'll see here fewer brain metastases, fewer visceral metastases in general in those patients who got nivo chemo, whereas local regional recurrence is quite similar across the two arms. In terms of ctDNA clearance, we here have now close to 4-year follow-up, and again, a trend towards those patients who cleared ctDNA during the neoadjuvant phase tend to have a better outcome than those who did not clear ctDNA. And there was one other arm to this trial. This was the ipilimumab-nivolumab arm. This was discontinued early because of the changes in treatment of advanced lung cancer, where chemo plus PD-1 became the standard therapy. However, we reported the results of this arm earlier this year in the Journal of Clinical Oncology. This arm also showed an impressive increase in pathologic complete response. So those patients who got 6 weeks of nivo-ipi had a PCR rate of 20%. Versus just under 5% with chemo alone. And there was a trend towards an improved event-free survival with nivo chemo. And this was an exploratory analysis, so it was underpowered. Important thing to note here, though, these curves do cross. So in contrast to the chemo-nivo versus chemo, so initially chemo seems to do a little bit better, and then later on nivo-ipi catches up. And this is a concern if you're in the perioperative or neoadjuvant setting, that perhaps some patients will lose the opportunity to have surgery. KEYNOTE-671 was the first trial to show an overall survival benefit from immunotherapy in early stage disease. This was a study which enrolled patients with a pathologically confirmed resectable stage 2, 3A, or 3B, so moving to even more locally advanced disease, randomized to cisplatin-based chemotherapy plus pembro, or cisplatin chemotherapy plus placebo, followed by surgery, and then up to 13 cycles of adjuvant pembrolizumab or placebo, with the primary endpoints of EFS and OS. You'll see here, as I mentioned, so we're seeing more late-stage patients being enrolled in these trials. Slightly higher proportion in this study of PD-L1 positive disease, about 65% versus 50% in the Checkmate 816 trial, and a small number of patients with EGFR mutant disease enrolled. First of all, as you might expect, event-free survival was positive, as a ratio of 0.59 favoring the pembrolizumab. And then at the second interim analysis, overall survival was also positive, so hazard ratio of 0.72. Now, this is not dramatically different to the Checkmate 816 trial, but it was positive at an earlier part in the life cycle of the trial. And this is probably because this is a much larger clinical trial, almost twice as many patients enrolled compared to Checkmate 816. Which patients appear to derive less benefit potentially? So if we look at the numbers here, those patients who were older, which you might put down to more intensive therapy, not delivering benefit. Strangely enough, patients from East Asia didn't appear to derive benefit, and never smokers, which might make some sense. Also potentially PD-L1 negative disease. However, we see the same difference here by PCR. So those patients who have a PCR have a very long event-free survival, has a ratio of 0.33, but there is potentially some benefit also for those patients without PCR. And this is one question, is whether those patients who without PCR might derive more benefit from perioperative therapy. Briefly to talk about the Aegean trial, so very similar design here. One of the main differences were patients who might need a pneumonectomy were excluded from this trial. And also all patients were tested for EGFR ALK alterations. Primary endpoints were pathologic complete response and event-free survival. And all patients in this trial had to get were permitted to have either carboplatin or cisplatin. Again, positive for PCR, pretty clearly so, and also positive for event-free survival. We're still waiting for overall survival from this trial, but this has been approved in the US by the FDA as the second perioperative regimen after KEYNOTE-671 to be approved. We also have some quite nice data from this trial looking at ctDNA clearance and pathologic complete response. And it does appear that the main use so far would be those patients who don't have ctDNA clearance are very unlikely to have a PCR. So a very small number of patients who have persistent ctDNA actually have a PCR. Finally, CheckMate 77T. Again, I'm not going to belabor the point, but a very similar design. This study allowed both cisplatin and carboplatin as well, up to 1 year of adjuvant nivolumab. So again, very similar design to the other two trials. And again, positive for event-free survival and a very significant difference in pathologic complete response. In terms of one interesting finding from this trial was looking at patients with stage 3 N2 versus non-N2 disease. And there appears to be similar or even perhaps more benefit for those patients with N2 nodal involvement. So historically, surgeons have shied away from resecting N2 disease, but here we're seeing that in the era of neoadjuvant perioperative therapy, there's significant benefit from this systemic treatment. Another interesting finding from this study was looking at a landmark analysis, which was published in the New England Journal, landmarking from the time of surgery and trying to tell what the potential benefit for nivolumab in the adjuvant setting might be. And in both, again, patients with PCR and those without PCR, there appears to be benefit from further treatment. So this is a summary at the moment. These are the reported trials. You will see relatively similar hazard ratios between KEYNOTE-671 and CheckMate 816. We're looking forward to seeing the overall survival data from 816 at ASCO and to see will it continue to be similar to KEYNOTE-671. We did this analysis presented at World Lung last year, trying to tease out which patients from 77T might derive benefit from the adjuvant setting. And here we looked at CheckMate 816, so individual patient level data, including patients who had surgery in CheckMate 816, which is about 80%, and 77T, those patients who had surgery and received at least one dose of adjuvant nivolumab. With the primary endpoint of this analysis was event-free survival landmark from the time of surgery, and we used propensity score weighting to try and make these patients from different studies as alike as possible. And there was a similar duration of follow-up in the two trials. So here, when we look at landmark event-free survival from definitive surgery, it does appear using the two weighting methodologies that there appears to be some benefit in the overall group from perioperative therapy. However, it should be noted that there's some bias here and that to be in the perioperative group, you had to receive that first dose of adjuvant nivolumab. So, however, even in those patients who didn't necessarily get adjuvant treatment in CheckMate 816, you'll see here in the small print, the hazard ratio still favors perioperative treatment. Can we look at some subgroups? So in the PCR group, it's very hard to improve the outcome for a patient with a PCR by giving further treatment. So while the hazard ratio trends in that direction, the curves are almost indistinguishable. Whereas in those patients who don't have a PCR, we do see the curve separating and potentially favoring perioperative therapy. Again, patients with PD-L1 positive disease derive a lot of benefit from neoadjuvant treatment, so it's hard to separate those curves further. However, in PD-L1 negative disease, you do see a trend towards benefit from giving further treatment after neoadjuvant chemonivolumab. Overall, what about adjuvant versus neoadjuvant? So I'm a proponent of neoadjuvant therapy. We would expect that adjuvant therapy and the trials of patients getting just adjuvant therapy, the overall outcomes should be better. But ironically, we're seeing the 18-month disease-free survival, for example, in CheckMate 77T is 70%. Whereas in PEARLS, where the patients have already gotten through surgery, gotten adjuvant chemo, it's not that dissimilar. So I think there is a clear kind of indirect suggestion here that we should be looking at neoadjuvant chemoimmunotherapy for more patients. One last study to mention is the NeoCOAST-2 trial. This is a trial which is trying to create a platform for studying novel agents in the neoadjuvant setting, lung cancer. Tina Casconi, my colleague, reported 3 of the arms from this trial that were lung. This was oleclumab plus durvalumab plus chemo. That's a CD73 antibody, monalizumab, which is a NKG2A antibody, and then a Aerodigestive, which is a TROP2 ADC. And here we see an indirect comparison. The highest pathologic complete response here was with the TROP2 ADC plus durvalumab and chemo. And this, I think the idea here is to get a signal from this phase 2 trial of which agents should potentially move into a phase 3 trial in the neoadjuvant setting. And here we see a PCR rate of 34% with Dato-DXd, a lower rate with monalizumab, and lower again with oleclumab. So I think there's potentially a signal here that TROP2 might be a target in the neoadjuvant or perioperative setting. There's also several studies ongoing trying to tease out the contribution of phases in the neoadjuvant perioperative setting, including the study which we're involved in called ADOPT Lung, which is randomizing patients to get neoadjuvant chemodurvalumab and have a full resection to either observation or to continue durvalumab for up to 1 year. And this hopefully will give us an idea as to what the contribution of the adjuvant phase is. So again, we're back at this graph or this figure. My suggestion is perhaps to consider perioperative therapy for those patients who have higher risk disease, don't attain a PCR, have PD-L1 negative disease, but I would posit we need a lot more data in this setting. We do see that neoadjuvant or perioperative therapy confers more benefit than adjuvant only for most patients, particularly in the context of immunotherapy. The highest benefit is for clinical stage 3 disease, and I think here it is a clear standard of care. And trials are ongoing to evaluate the contribution of components, including the ADOPT Lung and other trials. Exploratory analysis suggests that patients with higher risk disease may need to derive greater benefit from perioperative therapy. So thank you very much, and I'm very happy to discuss further any comments or perspectives people may have.